So hope we have a good session today. And I'm Dr. Geeta, one of the consultants from Institute of Reproductive Medicine, Madras Medical Mission. So I'll be here with you for the CME today. So without wasting much time, I would invite our head of the department, Dr. Kundavi ma'am, to give a welcome address for the webinar today.
Thank you, Geeta. It's my pleasure and honor to welcome all the faculty, in spite of the busy schedule, who have joined us for this webinar on recurrent pregnancy loss. Uh, the faculties like Dr. Deepa, Dr. Kadirvel, Dr. Jay Shamin, and the moderator, Dr. Usha Vishwanath ma'am, and the panelists, Dr. Vijay Gnanashekaran, Dr. Bhuvna, Dr. Meena Mahalingam, Dr. Tarak Rishri, and Dr. Gigi Matthew for this webinar. I'm sure the delegates are going to benefit from this webinar on recurrent pregnancy loss. Over to you, Dr. Geeta.
Okay, ma'am. Thank you. Thank you so much, ma'am. So I think we can start with our first interesting session today. So we'll have Dr. Deepa Tyagarajan for the topic today would be how to evaluate recurrent pregnancy loss. So first we can go with the evaluation and then the management. So our Deepa ma'am, she's a consultant in Ops and Gynec, and she's a consultant at Motherhood and Rainbow Hospitals. So ma'am, can we start and can you share your
Yeah,
slide?
will do. Thank you. Thank you very much to MMM and Dr. Geeta and Dr. Kundavi for this invitation. I'm sharing my screen now. Is it seen as a slideshow?
Yes, ma'am.
Yeah. So as we all know, that it is very frustrating when somebody comes with recurrent pregnancy loss. And you might have seen quite a few people walking in with all kinds of investigations possible to evaluate this recurrent pregnancy loss. I'm glad that you have chosen a good topic to at least look at the evidence, what it says, and what exactly we need to know, and what tests we need to be avoiding. One, to relieve the frustration for the parents who are already distressed, and also to save quite a lot of money for them. So just to begin with, sporadic miscarriage means occurring most commonly in the first trimester, often the result of random fetal chromosomal anomalies. It increases with age and may affect 10 to 50% of women aged 20 to 45 years. Then recurrent pregnancy loss, there's always been a controversy regarding the definition. European Society of Human Reproduction and Embryology says loss of 2 or more pregnancies before a pregnancy reaches viability, which is less than 24 weeks. Primary recurrent pregnancy loss is no previous viable pregnancy beyond 24 weeks. And secondary RPL is 1 or more previous pregnancies progressing beyond 24 weeks. And RCOG, Royal College, says recurrent miscarriage has been defined as 3 or more first trimester miscarriages, and the incidence is around 1%. And the American Society also says 2 or more first trimester losses, and those documented by ultrasound scan or histopathology. Now, if we use 2 miscarriages, the incidence would definitely go up by 1.9% from 1%. And if we take 3 miscarriages, then the pooled risk is about 0.7%. Lancet, there was an article in 2021 which challenged the traditional approach of giving support to the woman only after 3 miscarriages. They called for a worldwide reform to improve the care and support of the couple even after 1 miscarriage and not just after 3. So there are various inconsistencies. The other inconsistency is, do we take ectopic and molar pregnancy? Should that be included? And then where is the time limit we take at? So there are various inconsistencies with all of this. Let us move on to how we're going to evaluate this patient. First and foremost is taking a detailed history where we look at the maternal age, paternal age, detailed obstetric history, number of previous miscarriages, previous live birth, ethnicity, BMI, smoking, alcohol history, caffeine history, and environmental chemical exposure. Especially in obstetric history, we need to know the gestational age at which the previous pregnancy loss happened and what kind of treatment they received for this previous pregnancy loss. We also need a full medical history regarding thyroid and diabetes and a family history of any thrombosis. So the most common cause for this miscarriages is genetic. And chromosomal anomalies of the pregnancy are the commonest cause of both sporadic and recurrent miscarriage. And 50% of the sporadic miscarriages are a result of fetal chromosomal anomalies like trisomy, polyploidy, monosomy, structural anomalies, or others. And the incidence of aneuploidy in recurrent miscarriages is 40%. And non-genetic factors also play an important role. The newer studies which have come, which uses microarray techniques, have been reporting a higher number of cytogenetic anomalies with sporadic miscarriages up to almost 60%. And if there is a miscarriage of a euploid pregnancy, that is associated with an increased risk of a subsequent miscarriage. How are we going to test them? Cytogenetic analysis of the pregnancy tissue will provide a diagnosis in 90% of the couples. Identifying those with balanced chromosome rearrangements is what we are looking at. And the technique for analysis of pregnancy tissue is either you do a conventional karyotyping or a FISH. Array CGH is what has been recommended now. And the other tests which are available are single nucleotide polymorphism and next generation sequencing, or the NGS. And for genetic analysis of the pregnancy tissue following a pregnancy loss, array CGH is recommended based on a reduced maternal contamination effect. Parental chromosomes. Parental chromosome rearrangements and the risk of subsequent miscarriage. Parents can have reciprocal translocations, inversions, Robertsonian translocations, and other types of chromosomal anomalies. And the chances of parents with balanced structural chromosomal abnormality having a healthy child is almost 83%, which is almost the same as control couples, 84%. So when should we do a parental blood karyotyping? That should be offered when the pregnancy tissue reports an unbalanced structural chromosomal abnormality, or testing of pregnancy tissue is unsuccessful, or when there is no pregnancy tissue available for testing. If abnormal parental karyotype is identified, then we need to give genetic counseling of the couple and familial chromosome studies should be carried out. So RCOG advises selective parental karyotyping only when an unbalanced chromosome abnormality is identified because of the high costs involved. Then thrombophilia. We have two types of thrombophilia, the acquired or the inherited. Acquired thrombophilia, it's been shown that there's an increased risk of recurrent miscarriages, particularly for lupus anticoagulant, which has the strongest association, and anticardiolipin antibody, which has the second strongest association. Ma'am, somebody needs to mute their microphone, ma'am. We are able to hear what you're talking.
Yes, ma'am. I'll just.
Yeah. Adverse pregnancy outcomes. When do we check for acquired thrombophilia? When there are 3 or more consecutive miscarriages before 10 weeks of gestation, 1 or more morphologically normal fetus after the 10th week of gestation, and 1 or more preterm births before 34 weeks of gestation because of placental disease. What is the test we do? Lupus anticoagulant and anticardiolipin antibody should be tested 6 weeks post-miscarriage. We need 2 positive tests 12 weeks apart, and we use the dilute Russell Viper venom time for the lupus anticoagulant and ELISA test for anticardiolipin antibody. Anti-beta-2 glycoprotein 1 antibody, evidence is less conclusive, but ASRM says we can test that as well. Inherited thrombophilia, factor V Leiden mutation, protein C, S deficiency, antithrombin deficiency, prothrombin gene mutation can cause systemic thrombosis, and they may cause recurrent miscarriage by causing thrombosis of the uteroplacental circulation. And it's more consistently associated with second trimester miscarriages. And out of these, factor V Leiden may cause first and second trimester miscarriage. Prothrombin gene mutation can cause recurrent miscarriage. Protein S deficiency can cause second trimester miscarriage, whereas protein C, MTHFR mutation, and antithrombin deficiency don't have any association. When we need to do the testing, Again, test for factor V Leiden prothrombin gene mutation or proteinase deficiency only if there has been recurrent second trimester miscarriages. And you have to test it only when they're not taking any hormonal medication. As there is no association between recurrent miscarriage and protein C, MTHFR mutation, and antithrombin deficiency, no need to test it. Anatomical factors, congenital uterine anomalies, prevalence is 13.3% and increased risk of miscarriages, especially with a septate and a biconvate uterus. Both first and second trimester miscarriage can happen, and 3D ultrasound scan is the gold standard to diagnose uterine anomalies. You can differentiate septate and biconvate very well using the 3D ultrasound scan, and it is low cost and highly acceptable. Advanced investigations like MRI and endoscopy should be reserved for complex anomalies or when diagnosis cannot be reached with 3D ultrasound. So ultrasound scan can also help you diagnose fibroids, like especially submucous fibroids, polyps, and intrauterine adhesions, which can cause higher sporadic miscarriage rates. Cervical integrity. Cervical insufficiency or shortening of the cervix diagnosis is mainly clinical and with a history of second trimester miscarriage with a painless cervical dilatation where there has been intact membranes and expulsion of a sac and a live fetus. Previous cone biopsy in the history or a short cervix on ultrasound scan can also diagnose cervical insufficiency. Coming to endocrine, again, when you look at the endocrine, when there is a well-controlled diabetes and thyroid disease, there is no increased risk of recurrent miscarriage. When you have a subclinical hypothyroidism and thyroid antibodies, it has increased risk of recurrent miscarriage. Similarly, polycystic ovarian syndrome also has an independent increased risk of recurrent miscarriage, and a prolactin imbalance also has an increased risk of recurrent miscarriage. Luteal phase defect shows insufficient evidence. Thyroid function test and thyroid peroxidase antibodies are important tests to be performed. Other endocrine tests are not routinely indicated. If there is a clinical suspicion of either hyperprolactinemia or diabetes, then go ahead and check for these two. Immune factors, again, peripheral immune factors like HLA, cytokines, and peripheral natural killer cells, they have shown insufficient or inconclusive evidence in association with recurrent miscarriages. And women with recurrent miscarriages should not be routinely offered immunological screening such as HLA, cytokine, or NK cell tests. Uterine NK cell density, insufficient, again, inconclusive evidence. There have been studies which have shown increased NK cell density in the endometrium in women with recurrent miscarriages. Infective factors, left, right, and center, everybody do a torch screen. Are we justified? Torch and listeria, insufficient or inconclusive evidence, hence torch screening should not be undertaken. Bacterial vaginosis may show an increase in second trimester miscarriages. Chronic endometritis is also implicated in recurrent miscarriages. Future molecular studies on microbiome of the uterine cavity may shed more light, and women with recurrent miscarriage should not be routinely offered infection screening. Finally, male factors, sperm parameters, there could be an increased risk of recurrent miscarriage with increased sperm DNA fragmentation, nuclear chromatin decondensation, and sperm aneuploidy. Then do we go ahead and do a sperm DNA fragmentation for everyone? No, just take a detailed history and only if absolutely necessary, do DNA fragmentation test. So we all know the risk factors, female and male age, chronic endometritis, smoking, high BMI, alcohol, medical and family history, and a complete pregnancy history. And the guideline development group recommend to base the prognosis of a couple with RPL on the woman's age, her complete pregnancy history, including the number of previous pregnancy losses, any live births in the past, and their sequence in which it happened. So to summarize everything, the key recommendations are clinicians can recommend extensive evaluation after 2 first trimester miscarriages if there is a suspicion that the miscarriages are of pathological and not of sporadic nature. Test for acquired thrombophilia, which is lupus anticoagulant and anticardiolipin antibody, should be done prior to next pregnancy. Second trimester miscarriages may be offered factor V Leiden prothrombin gene mutation and protein S deficiency, but not a must. Inherited thrombophilias have a very weak association with recurrent miscarriages, and a routine testing of protein C, MTHFR mutation, antithrombin deficiency is not recommended. Cytogenetic analysis of the pregnancy tissue should be offered for third and subsequent miscarriages and in any second trimester miscarriage. Parental karyotyping, when testing of pregnancy tissue reports an unbalanced structural chromosomal abnormality, only then you offer parental karyotyping, or when the tissue which you tested was unsuccessful or no pregnancy tissue was available for testing, then you do a parental karyotyping. Offer a 3D ultrasound scan to assess for congenital anomalies of the uterus. All women should be offered thyroid function test and thyroid peroxidase antibodies. And women with recurrent miscarriages should not be routinely offered immunological screening such as HLA, cytokine, natural killer cells, infection screening, and sperm DNA testing. Finally, women with recurrent miscarriages should be advised to maintain a BMI between 19 and 25. They should stop smoking, limit their alcohol, and limit caffeine to less than 3 cups a day. And women with APLA positive are given aspirin and heparin up to 34 weeks of gestation. And routine use of pre-implantation genetic testing for aneuploidy is not recommended. Recurrent first or second trimester miscarriages with a septum can be offered resection of the septum. And progesterone supplementation in women can be given 400 milligram micronized progesterone. The PROMISE trial has said you can give it twice daily up until almost 28 weeks of gestation. And routine thyroxine supplementation in euthyroid women with TPO is not necessary. And most important is offer these women supportive care, especially if you can, in a dedicated recurrent miscarriage clinic. That is to summarize all the evaluation which is required. Hope it was useful. Thank you for your patient listening. Thank you, ma'am.
Thank you. Thank you so much, ma'am. Thank you for elaborating on the investigation part. I would like to say, madam might leave after her talk. So if any doubts on investigation, you all can ask now. Ma'am, I just wanted to know, so you have elaborated on the investigations. Can you just give us in just like if a young female who, for example, a 28-year-old married for 1.5 years, have got 2 miscarriages, what are the investigations you would like to do? Yeah, I mean, whatever has supported by evidence and not supported by evidence you spoke.
Yes, depends on whether they've had any testing of the. See, first of all, you need to take a detailed history. At what gestation did the miscarriage happen? Whether it was less than 10 weeks or more than 10 weeks. If you've had even one miscarriage where you've had 8 weeks, there's a fetal heart, 10 weeks, there's a fetal heart, 12 weeks, you see there is no fetal heart, then definitely you have to test even if it is after a single miscarriage. But if it is less than 10 weeks, and then you can wait for 2 miscarriages to investigate the couple. If it is more than 16 weeks or 24 weeks, then you need not have to wait for 3 miscarriages to investigate this couple. And what are the basic investigations you will do is, if they are between pregnancies, offer a lupus anticoagulant and anticardiolipin antibody. Definitely do thyroid function and thyroid peroxidase antibodies. A detailed ultrasound scan to rule out any uterine anomalies. These are the basic things which is necessary. And if the BMI is high, then you do a sugar test also. And what else you can ask them to do is lifestyle modifications, reduce weight before they conceive.
If at all patient is pregnant and she has had 2 miscarriages, like less than 10 weeks with fetal heart, 2 previous miscarriages, and third time she is pregnant and she has come to us and she has
Yes.
not been evaluated anything.
Yes.
What about the APLA investigations when
Yes. So sometimes the hematologist says, even if they've had APLA investigations and has come as negative, or they've never had any investigations, again, they can be seen 12 weeks or before and repeat an APLA investigation during their pregnancy also.
Okay. Okay, ma'am. Thank you. Thank you so much. So maybe we can move on to the next session. So we are moving on time.
Thank you, ma'am. Thank you.
Thank you so much, ma'am. You have stopped sharing your screen, ma'am.
I have, yes.
Okay, so we move on to the next session where we all are mostly worried and especially to give an answer to a couple when they come with recurrent miscarriage, whether genetics play a role or not. So we have Dr. Kadirvel with us to elaborate on genetic role in RPL. Dr. Kadirvel has done his DM medical genetics and he's a clinical geneticist in MedGenome Lab. Sir, over to you and you can start sharing your screen here. We welcome you, sir. Sir is there.
Am I audible and my screen is visible?
Yes, sir. Yes, sir. Done.
Very good afternoon, everyone. So I'll be focusing mainly on the role of genetics in RPL. And as we know, the role is currently evolving and predominantly we are now moving from clinical domain to research domain. So I'll be focusing on this genetic causes of RPL and the concept of embryonic fitness and how the genomic approach has evolved and what is the current clinical role it plays and what are the future prospects in this field. So we have multiple bodies endorsing different definition. Then it came to two or more recurrent pregnancy loss, and it has been found that predominantly it is genetic and predominantly it is chromosomal. But as we saw, the chromosomal anomalies in leading to RPL can predominantly be a chromosomal issue within the POC, or it can be inherited to the parent, which can lead to a major cause, which can be a major contributor compared to other causes of RPL. But we should always remember the executive mechanism how abortus goes through, or like during the process of abortion, would be a product of both the gene and environment. The predominant mechanism is at the level of the tissues would be this immunological rejection compounded by apoptosis and excessive oxidation stress. So coming back to the basics, so obviously the genetic cause of RPL is predominantly aneuploidies. It can be inherited to the parent through structural rearrangement. And the early ones are the unusual aneuploidies, which don't survive through the first pregnancy, whereas the typical aneuploidies can present with the late trimester abortions. And there are multiple genomic defects, such as single gene defects, which are now building up in this domain. Predominantly
Excuse me, sir.
some monogenic disorders.
Sir, can you be a bit louder? Your audio is not clear. That is what we hear from. Increase the volume.
Okay, ma'am. I'll try. Am I audible now, ma'am?
Okay, sir. Go ahead.
So the single gene defects, there are some single gene defects which can present with immediate early abortions, and the list is now increasing rapidly because there are various genes which have been studied in this domain of immunology, immunogenetics, and the implantations. We have various thrombophilic gene mutations as well as mutation involving the regulatory enzymes are being studied up in this domain. So I just want to highlight the concept of embryonic fitness. So obviously any embryo which is euploid, well imprinted with low mutation would confer high genomic fitness, would undergo successful pregnancy, and any deviation at any level, be at the level of chromosome or at the level of gene, can tip the balance. And obviously this would trigger either a development arrest of this embryo or can result in implantation failure. And the third outcome would be the miscarriage. So these are the mechanisms which can operate at different level of genome of the embryo, which can lead to abortions. As we can see, the most commonly we see is aneuploidies, which can trigger a global gene dosage balance with the subsequent mechanism leading to abortions. But the other genetic aberration, what we see in embryos, can predominantly lead to a miscarriage due to the gene dosage imbalance. But not only at the level of chromosomes, we have various mechanisms which to play at the level of genes as well as in the level of the mitochondrial genome as well as the epigenome. And we are now seeing more in the level of the mitochondrial load of the ovum, which was subsequently fertilized, to play a maximum role in the energy failure, which can be a mechanism for the embryonic loss. So so coming to the basics, so as ma'am highlighted in the previous talks, yeah, parental chromosome study would be mandatory because both the reciprocal or Robertsonian translocation parent can lead to recurrent pregnancy loss. This would be identified only if parents are tested with karyotype. And obviously, chromosomal aneuploidy can happen de novo. So this, as emphasized in the previous talk, would require the evaluation of POC with a microarray along the compared to the traditional karyotype. So moving to the single gene disorders, we now are seeing rarely this autosomal recessive disorders, which are being implicated in this recurrent pregnancy loss. There are few genes which can trigger this event of recurrent iridiform mole leading to recurrent pregnancy loss. And there are, as we know, there are few other genes which are studied in this particular pathways. As ma'am highlighted previously, genetic thrombophilias, yeah, we have seen few patients presenting with this common thrombophilic mutations, elevating the risk of thrombosis in them. However, the current recommendation to work any patient in terms of hereditary thrombophilia is little arbitrary. And there have been usage of assays for quantifying them, but predominantly it is done at a later period post-pregnancy loss, as we know the physiological change occurs. However, the genomic approach would be more confirmatory in this group of patients. So moving on to other single gene culprits, yeah, some genes involved in the process of embryo development can halt the embryo progression, leading to molar pregnancies. And genes involving this mitotic segregation can also result in aneuploidic embryos with early loss. And there are few genes which can characterize this decidual involvement of trophoblast and can lead to mid-trimester miscarriage. However, the contribution of single genes in this domain is evolving, with currently only uh, very less case reports are being reported with these genes. So there is evolving role for polygenic, epigenetic, as well as male factor studies in spontaneous, in recurrent pregnancy loss. In epigenetic factors, people are now evaluating the methylation status at the level of embryos, which can harbor the progressive decidualization of these placentas. And they are studying both this maternal as well as various histone modifiers in this domain. And paternal sperm epigenome defects can also contribute to recurrent pregnancy loss, where people have studied the microRNA or expression levels in semen analysis to quantify the same. So polygenic factors are on the rise, but however, there is no current utility for the same. So people are now coming up with a polygenic risk score to quantify and stratify our patients and look for any possible clinical management in this patient based on this polygenic risk score. People have studied either for thrombophilic polygenic risk scores and also this endometrial receptor SNP sets. However, currently it is in the exploratory domain, and it has been predicted that people would come up with better polygenic risk scores in the future. So this is how I want to highlight how genetic testing has evolved in RPL. So previously we were doing conventional karyotype, predominantly more than 3 miscarriages. Then came domain of testing POCs. We were using fish, or we were using traditional karyotype. Then we moved on to PCR based assay. We were even focusing on thrombophilia genes, the panels for focusing on the common thrombophilia genes implicated in RPL. Then we moved to chromosomal microarray, which has now almost replaced karyotype in studying POCs, where we could detect better submicroscopic deletions or duplications. And we now are moving to the era of NGS, where NGS is now being supplemented in looking for monogenic cause, and expanded carrier screening assays are coming up in a better way, where they are also working on this risk prediction in couples with recurrent pregnancy loss. And future prospects is moving in this field towards PGTs, where PGT, A, and SRS come studied in a better way. And people are also trying to go for trio approach of studying exomes, genomes in parents as well as the POC to go for better polygenic risk score based on risk prediction model as well as epigenomic profiling is also attempted. And there is much research-based multi-omic integration which is being tried, where not only the study of genome, people are trying to work at the level of transcriptome and proteome, combining with the uterine microbiome. So AI-guided risk prediction is also studied for the same. So now coming to the basic thing where we go about what sample to be used and what we use. So obviously the sample either we use the POCs or the maternal fetal blood, both as individual advantage regarding the timing, the sampling procedure as well as the prognostic value. So there are various methods, but currently clinically we are limited to karyotype, the microarrays, and rarely in exploratory terms exomes can be done, and rarely some centers they opt for genomes, predominantly in the Western setting. So the role of POC karyotype is still redundant because of the culture failure, MCC, low resolutions. So however, it can sometimes help in picking up the the balanced translocations, which can highlight us in working up the parents. So the initial studies showed a better quality of better role in primary RPL compared to secondary RPL. And even with the number of miscarriages, also it was studied the yield would be better in subsequent miscarriage than the earlier miscarriages. And coming to parental karyotype, currently it is being explored only when we suspect an setting of an inherited chromosomal event. And definitely a parental karyotype would be useful in identifying the balanced translocation carrier, which is 1 in 250 to 400 in our population. And however, it may not be effective in all cases, and it has to be decided case to case basis, as Madam previously highlighted. And so, as we can see, working on the parental karyotype can ideally become can help us in stratifying our patients, and definitely it can be a modality in contributing to successful pregnancies. And moving on to the POC CMA, it has now almost taken up karyotype because of the better identifying strategies, and it can pick up with better resolution, even the segmental genomic imbalance. But the compared to karyotype, the additional diagnostic yield contributed to microarray is significant. With these are the highlights, we can use it in formalin tissues, no culture failure, high resolution, and various studies have highlighted the same better outcome compared to the routine karyotype based analysis, and the better yield compared to the conventional karyotype based analysis. The add-on values have been studied in multiple systemic reviews and meta-analysis, showing the high utility of chromosomal microarray over karyotyping. Moving on to the usage of whole exome sequencing in RPL, currently it has been limited to only few case-to-case basis modalities, where patients who have studied with RPL have where genomic mutation in families with the parents have been identified, and predominantly we have success in cases involving this genes which are involved in the cell adhesion and cell matrix remodeling or angiogenesis. Predominantly, this genome network pathways which are involved in angiogenesis and placental implantation and this trophoblast proliferation mechanisms. So this has led to this modality of PGT is currently the role is evolving, and currently there are few success which are being highlighted by few centers, predominantly in PGTA. But people are now also moving to PGTM, and case-to-case basis, few success are also being identified. Moving on to future prospects, yeah, this is how the future prospects look like. So people are now moving to other omics domain such as transcriptomics and epigenomics. There are few role where people are working on biomarkers for early pregnancy loss, just to couple the biomarker along with the clinical follow-up of patient. And some centers have even looked for placental transcriptome profiling to look for functional categorization of genes, to look for gene predisposition and studying the expression of the same. They have studied, and there are few gene networks and pathways have been highlighted on the same, but the role is still evolving. So moving on to the clinically used investigation. So currently we are working mostly on the chromosomal analysis of POC only after the second loss, and we use microarrays first, and the parental karyotype would come on case-to-case basis, or if we identified an unbalanced translocation or inversion. However, the role for other mechanisms, other modalities are highlighted would predominantly as future prospects, and the evaluation would still evolve. It's still evolving. As we know, Madam has also highlighted the RPM management would be multidisciplinary, and genetic counseling would be the role currently when we identify any genetic cause. But the future is evolving in this way, where people are now planning for trio whole genome along with the rapid POC analysis, so that a real-time quantification of a lethal variant can be done. And various centers are coming up with polygenic risk scores to look for implantation compatibility failures, etc. And they are also incorporating the same in PGT platforms, so that a single assay can work well for planning the subsequent pregnancies also. And AI enhanced embryo selection is actually come up. There are a few startup in US who are who have been currently offering the same, where they are trying to counsel the couple with their possible, the embryos are being generated and they are studying using omics tools, and each embryos is quantified with a polygenic risk score, and people are coming up with this high fitness embryo concept, where an AI-based model can give a better score to quantify which embryo can be used in subsequent pregnancies. And the epigenome microbiome are also studied, so that modulation of the same can help in rescuing these borderline embryos, as gene environment role plays a major mechanism in the same. So just to answer the question, yeah, it is the role of genetics is currently limited, but it is evolving. So future it may be working on this AI-based polygenic risk scores and epigenomics, as well as a better risk prediction model to address this couple with recurrent pregnancy loss. Thank you.
Thank you, sir. Thank you so much about your role of genetics in RPL. Sir, I have a doubt. If
Yes.
we have two losses, pregnancy losses, then we are going to evaluate with the products of conception. And only when we find some unbalanced translocation or something, we are going to do karyotyping. This is a general rule which we are following. But what about this whole genome sequencing? That is done only with NGS, or it can be done with other platforms also?
Yes, ma'am. So whole genome sequencing is currently best studied with NGS because of the cost affordability, as well as NGS is currently can provide an whole genome assay in a very because NGS is just a platform. There are multiple methodology, sequencing chemistry, which is now coming up in this domain also. But the whole genome based assay would be more cost effective comparing to an microarray based platform. And as even few companies are even providing this whole genome assay at the level of POCs also. So definitely it would completely take over in future, but still in our clinical practice, we are now restricted to microarray evaluation of POCs. But in future, we are looking up to whole genome based assays, both for even people are evaluating even parents with whole genome based assay to combine the risk score also, and to study other causes also in the same setting.
But will it not be costly, sir? NGS?
Exactly, ma'am. So the cost, true to say, the cost was 5 years back, it was 60,000, but nowadays it is coming, the assay is now 40,000, and the prediction are coming, we may get even a $100 whole genome assay in the future in coming 3 years. And as we know, the exome has come down to 8,000, so there are high promises in this field. We may get even a whole genome assay in less than 10,000 in coming years, ma'am.
Okay.
It's coming as a package now, Kadir.
Yes, ma'am.
It's coming as a package now, right? The whole sequence.
Yes, ma'am, whole genome, but the problem is currently whole exome is being done for parents only in carrier analysis. So, but the role for evaluation of RPL would be less limited. It's limited because only very less genes are incorporated, implicated on the same. So, but people are now moving to an whole genome assay, so they can study all genes, and even the experimental genes implicated in RPL are also studying the same assay. But currently we are not, we are just using a whole exome based carrier assays, which is limited in studying this RPL based genes.
Accuracy wise, you prefer microarray or whole genome studies?
No, ma'am, whole genome can equally do their job well. So the carrier track where some companies use, where they use an SNP markers to get the whole genome based assay, I would say because the cases we worked up, we feel almost 100%, 98% concordance in our cases. There are only few disadvantages in whole genomes. Only some structural variants can be missed out because of the quality of assay. But now I would, because with upcoming platforms, even the quality is better improved in subsequent versions. So I strongly feel that whole genome would replace CMA also in the future.
Sir, you mentioned about the rapid NOC NGS. So is it the same which we are talking, or it is something different?
Yes, ma'am. NGS is the platform basically. Yeah, we can do an whole genome assay in this like within 7 to 10 days we get the result, and it is predominantly done in where we actually need predominantly in prenatal setting. They try to couple with carrier analysis along with that along with the fetal genomics. So in that case, the rapidity would actually have utility because couple can decide on continuing the pregnancies and other steps on that.
Okay. Okay, sir. Thank you.
There's one question there, Gita, for him, a genetic one.
Sir, there is a question where the
I have a case with 7.
case with 7 recurrent pregnancy losses, wife having 46XX inversion 9P12Q13, and husband has got 46XYQH plus. And the doctor has given her plan of IVF PGT. Is it PGTA? Will PGTA help her or not? Need to do, or whether she has to do PGT-SR along with PGTA. Can you?
Actually, this one, so the husband carrier 46XY is just a heterochromatin. We can neglect that. And this inversion 9, I just want to see have a look in carrier. So it's look like the routine inversion, it's a more of an polymorphism, but better we can have a look in carrier and confirm the same. And regarding the PGT prospect, yeah, obviously, people are now, because in PGTA the success is actually good. And in PGT-SR, we have seen few success, predominantly in Robertsonian reciprocal translocation. And definitely, I would suggest it's based on the affordability and as well as the expertise at the level of the center. They can decide accordingly. And the second question, list of any genes which can be detected. So obviously, a whole genome assay would sequence everything. So there are in our genome, we have 23,000 genes, and all genes would be sequenced. Only the question comes to which genes are actively implicated. So the active genes which are implicated, the list is very small, but we have a very big of candidate genes which are being studied on the research basis. So, however, you should remember, ma'am, the whole genome assay would involve all the genes. So the same data would have longitudinal utility. So based on evidence and time to time reanalysis, the data may also change. So currently the role, we can pick up only a small list of genes, but the same data can be used in future to study the genes as the publication comes out. So it has longitudinal utility, and as time evolves, new genes being picked up, so the same genes can be studied in the same assays.
Okay. Okay, sir. Thank you. Thank you so much, sir.
Thank you.
See if there are any more questions, then we can catch up during the discussion session. So we can move on to the next session. So we have a gray area about this immunogenetics, immunology in reproduction failure. So we have Dr. Jai Shamin to talk to us on role of immunogenetics and immunotherapy in reproduction failure. So sir is a clinical director at Nova Wings IVF Group, from Ahmedabad. And sir, we are happy to have you here. You can share your screen here, sir. Sir?
Thank you so much for kind introductions. And I think so I'm sharing my screen. It's a very gray area, you rightly said. I think so very at present for a fertility specialist and for a fertility specialist as well as the gynecologists, those who are practicing, for them, it is also very difficult because we don't know what is immunology in our practice. And क्या किया ये? ये तो नहीं है. हाँ. So that's why I'm just sharing my slide. And today I'm going to able to explain recent advance. Recent advance कहाँ गया? नीचे है.
ये रहा ना recent advancing.
एक मिनट मुझे दे. Just a minute.
Okay, sir. No problem.
You know. भी शेयर पिक्चर एक ही है रिसेंट एडवांस ही शेयर जल्दी शेयर भी एक ही रिसेंट एडवांस नेशनल का लिया yes my screen is visible.
Yes, sir. Only thing you have
Yes.
to share it.
I'm just doing everything one minute. So the topic is role of immunogenetics and immunotherapy. I think so I'm audible and also my screen is visible.
Yes,
Can
sir.
Yes.
Yes, you can go
So
ahead.
role of immunogenetics and immunotherapy and reproduction failures. I will say reproduction failure. That means it's reproduction implantation, recurrent implantation failure, and also I can say it is recurrent pregnancy loss. Why we are thinking about the immunology, where we can think about the immunology, we can think when there is a recurrent miscarriage, more than 4 recurrent miscarriage in the younger group of the patients. We can think about when the patients will arrive at your clinic and they have a more than 4 or 5 single embryo transfers any other IVF center and they still not have any chemical pregnancy also. We can think about the immunology when there is the consecutive 2 or 3 euploid embryo transfers and still there is no any implantations, or after the 2 or 3 consecutive implantation transfer there is a recurrent miscarriage will be there after PGT normal, then we can think about the immunology. Let me tell you before I shift on any the how we can explore or open the black box of the embryo maternal crosstalk. I want to say something about this is the pyramid, nature pyramid of implantations. And in the natural pregnancy, the pyramid of implantation, if you can see that the 60% there is a preconception loss. And in this 60% preconceptional loss, we are able to investigate by the genetic testing of the embryo nowadays and transferring a genetically normal baby. But then what happened, even we transfer genetically a normal baby, and this is what I want to say that it means what? Even nature, when they transfer a genetically normal baby, there are some chance that there will be a no implantations. We can easily say that 30 to 40% there will be a no implantation if a genetically normal baby which was transferred, and it is none other than that we are not opening the crosstalk between the endometrium and embryo, and which is called we are not opening the maternal immune system reactions, and that is why we confuse. Now what we confuse that we don't know whether the egg is come first or chicken is come first, and same thing that we don't know whether the immunology come first, whether the endometrium we need to investigate for the implantation failure, or whether we need to investigate the embryo first. But by whatever our publication which was published yet, what we understand by that we believe that we'll first investigate the embryo. And we say that by the latest investigation, the retrospective data which was published, and they say the embryo is the most important cause behind any implantation failure. And look at this retrospective data. And here I think so 4,429 embryo genetically tested, single embryo, one by one transfer. And look at that, every time the normal clinical pregnancy rate is around 50 to 60% will be there. And at the end of the day, the clinical pregnancy rate will reach around 95% and the live birth rate is 92%. So there is no doubt about it that we are going to definitely transfer genetically normal embryo transfer one by one. A patient who is suffering from a recurrent implantation for a pregnancy loss as a first. But what if what is not answerable? Why a genetically tested normal embryo will not implant more than 30 to 40%? That there is a gap between the implantation, even the tested normal embryo in a good prognosis patient, there is 30 to 40% there is the implantation failure. It's not only implantation failure, but whenever we transfer this genetically tested normal embryo, there is around 7 to 10% pregnancy loss. So we are not able to exactly explain the couple, or we don't understand what is the reason behind the pregnancy loss, maybe after transferring genetically normal embryo. And then when we want to open, again, there is a restrictions. And look at this ASHRAE guidelines, which say something about don't go beyond genetic testing. And that's why we just stop and waiting for some guidelines from the Europe. That is what we are doing oftenly in our clinical practice, isn't it? I'm not going to wait. And what I explored yet, that why genetically tested embryo will not implant. I want to say something about regarding this guideline. That guideline is again an invaluable starting point. And I think so. It is not should be adapted blindly. Fertility care in India requires a balanced approach. I can say that global based practice combined with the local realities, by prioritizing clinical judgment and investigating in local research, we can provide a better care and achieve better outcomes for our patients. Let's focus on creating the India specific solutions while building on the global expertise that ASHRAE provides. So this is what my conclusion against the ASHRAE guidelines of the recurrent implantation failure and recurrent pregnancy loss. And now I want to open that why. What is the reason behind that genetically normal embryo still not implant after the consecutive 2 or 3 embryo transfer? What is the reason behind that there is a pregnancy loss or repeated pregnancy loss even after the assisted conceptions? Or what will be the reason where we can where there is a patient is having a multiple miscarriage which go beyond 4? Beyond 4, what I can do? And simply I can say the reason behind is a rejections from the maternal immune system. It's nothing but the maternal immune system rejections. And if I say something, we want to open that rejections. We do have some past studies, and these are the past studies which say that pregnancy is immunosuppression, isn't it? Pregnancy is immunosuppression. Later on in 2015, it was corrected that there is nothing like that. Pregnancy is a total immunosuppression. So why? Because whenever we are giving influenza vaccine, there will be a response. Why the patients having a viral infections or COVID infection during, and they develop some cytokine storm with the pregnancy, that means that immunity is not suppressed at all. It's all about her innate and adaptive immunity is still working during pregnancy will be there. That is what we observed in 2014 by the K et al. So now we understand the pregnancy is not the immunosuppression. Then what exactly the other system is working? And we know that it's all about something which is called as a immunotolerance, that I will explain you what is immunotolerance, which really required for the sustainability of the pregnancy. And today I will show you something about how HLA system is really responsible for the sustainability of the embryo and to reduce the recurrent implantation failure as well as the pregnancy loss. Let's understand what is immunotolerance. And that's we need to go back into innate immunity, adaptive immunity. Any foreign body virus, when it enter inside the blood, definitely there will be natural killer cell activations, and followed by there will be the B cell will produce the antibody, and which always again protect us by the other same virus exposure of same foreign body will expose again and again. So this is what we know as a fertility specialist. But how we implement in the reproduction science, So immunotolerance, I would like to say that whenever the genital tract will have an exposure with the sperm will enter inside. As the sperm enters the female immune system, the immune system identifies sperm as a foreign body. And if they identify the foreign body, there will be a natural killer cell activation in the initial sperm exposure. But then there will be, yes, natural killer cell will proliferate and they want to kill the sperms. But later on, by the again and again exposure of the semen, what exactly our adaptive mechanism, the adaptive immunity will work. And this antigen presenting macrophage cell, and they will collect this T cell and they will modify this natural killer cell or T cell from the thymus, and then they will convert into the from cytotoxic to cytolytic. So this T cell is become now cytolytic. And this is called as a Treg cell, T regular cell. And now this Treg cell is not only present inside the maternal bloodstream, but also they are present in the decidual cells. So this high level of Treg cell is responsible for the cytolytic response. And that's why they will consider as a part of the immunotolerance and they will protect the pregnancy. Not only that, they will also produce a paternal antibody. So now there is a presence of paternal antibody is there. So immunotolerance, look at that, what I exactly say that whenever the sperm will enter at the end of the day, that it will be a more Treg cell and antibody presence will be there. So this antibody will going to protect your embryo when embryo implantation will be there. This is again how hourly the exposure of the sperm and how our immune system as a natural killer system will behave. That is what we say that up to 24 hours, within a 24 hours, that our immune system will produce a paternal antibody as well as the Treg cell response in the maternal immune system is there. This is again one diagram that whenever this antigen will go, that what we are looking for, that yes, paternal antibody will present at the end of the day, and all the Th1 system, whenever the embryo will come, this all Th1 system is shifted toward the Th2, which is called anti-inflammatory antibody will be, anti-inflammatory T cell will be there. So now what exactly we conclude? Before the entry of the embryo, the environment which is called as a immunotolerance environment in the pregnancy is the presence of the high level of the presence of the Treg cell in the not only in the maternal bloodstream but also in the decidual natural killer cell. In the decidual natural killer cell where also this Treg cell is high. So now the conclusion is very clear. High level of the Treg cell and paternal antibody will suggest that a proper level of the immunotolerance after a natural intercourse. This is the schematic diagram which I want to say that after the sperm entry, the immunological response in reproductions will go by the T cell modifications and will form the more Treg cell, and they will always going to activate the B cell, and that's why the paternal antibody formations. And after paternal antibody formation, the GIF, what we can say when the embryo will come, all the antibody will surround the paternal antigen in the embryo and they will protect the embryo. So this response is must. This immunotolerance is must. I consider that woman is vaccinated. Now you will say, what, Dr. Jayesh, what you are saying? What is vaccinated? I want to say that intercourse is a vaccine. It acts as a vaccine. Because of the exposure of this vaccine, there is an immunotolerance and there is a formation of the paternal antibody and there is a modifications which lead to a formation of the Treg cell which will protect your pregnancy. Now, anyhow, I'm coming to the second point. This is one mechanism. The second point I want to say that is embryo transfer is really embryo transfer or it is an embryo transplantation. I say yes, embryo transfer is not transfer, it is a transplantation, but it is differ from the kidney transplantation. It is just not like kidney transplantations. How it differs? As embryo is a semi-allograft, that means 50% the antigen which might be not known inside the maternal immune system, which are new, which is the foreign body, which might be a virus, act as a virus, as a foreign body, as a transplant, as a graft in the maternal immune system will be there. But now I want to say that, is it in a past or even today, the estimation of the peripheral blood natural killer cell, is it necessary? And what will be the answer by understanding all this immunotolerance? There is nothing, because let me tell you that whenever there is an exposure of the pregnancy, there is no doubt about it that that T-Rex cell is always higher. And this decidual natural killer cell higher at the decidua or in the peripheral blood stream, both it is higher. That is called a physiological mechanism of the pregnancy. So there is no point that we are measuring the quantity. Quantity is having no role. It's all about that activation and deactivation of that decidual natural killer cell that I will explain in the next slide. But because of this slide, what we come to know that during the first trimester and also in the after implantations and in the first trimester, that decidual natural killer cell which is increasing, which is really helpful for the pregnancy protections. And that is why later on this all study which was published in 2010, and later this is the meta-analysis which was published in 2014, that measurement of the natural killer cell is having no role. So there is no role to measure this natural killer cell. It's all about the activation and deactivation of the decidual natural killer cell. Let's say something about now what exactly happens. So where paternal antibody is absent, the first what we can say this immunity, that if there is a paternal antibody is absent, there is no immunotolerance. Why there is no immunotolerance? That means there is no antigen exposure. Why there is no antigen exposure? Might there is no intercourse, or might that antigen is not antigen, it is just considered as a maternal body part. That means that genetic compatibility is matching. If brother and sister is there, then there are high chance that genetic compatibility is matching. So if their genetic alleles are matching, specifically it is more common when there is a consanguineous marriage, when there is accidental genetic compatibility, and even though the very easy assessment of the partner across the world. So initially we can't assess the partner globally, but now it is very easy to assess the partner globally as well. As these are all reason where I think so these accidents are increasing, because there will be a higher chance, increasing chance of the genetic compatibility in the both partner, and which in turn leads to no paternal antibody of the formations. And you can easily define by this diagram that whenever the embryo will enter in the maternal immune system, the antibody is present. If there is no antibody, then they are going to destruct the embryo. So no T-Rex cell, less number of the T-Rex cell and less number of the paternal antibody, definitely the embryo will reject it from the maternal immune system. It may lead to recurrent implantation failure, or it may lead to recurrent pregnancy loss, which is one of the cause. I don't want to say something, all the cause are there. This is one of the cause. So this is one mechanism of immunology. It is called absence of immunotolerance. Now let me tell you something, how embryo and endometrium or maternal immune system cross talk. How embryo will talk with the maternal immune system. And I think so, who will talk? The surface antigen will talk. So this surface antigen, it is called as a HLA, human leukocyte antigen. Any cell is having a surface antigen, which is called identification of the cell, which is a part of the HLA system and which going to talk with the maternal immune system. So now we need to see the HLA system. So on embryo, the extravillous trophoblast cell, which are in connect to the maternal immune system, they are having a antigen, and this antigen, it is called as a human leukocyte antigen system, and they have a two variety of the HLA system, a two variety of the antigen. One is class 1. So class 1 is presence on the cellular surface, and class 2 will be always in the maternal immune system. So now embryo need to talk with a class 1 antigen which is present on the extravillous trophoblast. They will talk with the maternal immune system, and they will also talk with the class 2 immune system which is in the maternal bloodstream. So let's say something about this class 1 antigen is having around 6 class antigen will be there, A, B, C, E, F, G. But and in class 2 in the maternal immune system, it is around D system, which is called DP, DQ, and DR. So let me tell you something. The C is more important. Why? Because look at this diagram, the table. The C is always on the surface, and G, E, F will be developed later on. A, B is not present in the surface of the extravillous trophoblast. And that is what I want to say, that we need to more going to focus on the HLA class 1 and C antigen which is present on the extravillous trophoblast. And later on pregnancy, when pregnancy after 16 weeks, 18 weeks, the other HLA receptor is important. This is called G, E, and F. So G, E, F is also present, but they will develop when the embryo becomes 16 to 18 weeks. So first, during implantation, we have a more important part, that the CHLA antigen which is present on the extravillous trophoblast, which are having a two type of antigen, the C1 type and C2 type. So two type of C antigen, because we are talking about more C because C is on the surface. Now we are opening the embryo maternal immune system crosstalk. So you can say that maternal immune system, that means uterine natural killer cell. So that means what? This class 1 antigen, specifically C1 and C2, will talk with the uterine natural killer cell, and this C1 and C2 will have a receptor, and they will either activate the natural killer cell or either they deactivate. And this balance of activation and deactivation will allow the embryo to penetrate and to develop 9-month pregnancy will be there. So now you understand that embryo maternal crosstalk can be done by the HLA. As C is on the surface, C is more important, which in turn connect with the extravillous trophoblast, and where two type of HLA-C receptors, C1 and C2, and this C1, C2 will connect with the decidual uterine natural killer cell, and they provide a response on activation and deactivation. So just simplify. This is the embryo. If you just magnify the embryo outer cell, then this is called extravillous trophoblast. And if you magnify the extravillous trophoblast, you will find on the surface the C receptor. And if you just find out that which type of C receptor will be there, two type of C receptor, C1 and C2. So you will find out either it is C1, C1, C2, C2, C1, C2, lot of variety, polymorphic variety is there. So now you will find out and expose which C receptor of that embryo. Is it C1, C2 combination is there, or it is C1, C1 combination, or it is C2, C2 combination, or maybe C2, C1 combination. And that C1, C2 combination, now they will act with the decidual natural killer cell. They will activate or deactivate the decidual natural killer cell. If they activate, then embryo will penetrate. If they deactivate, and there will be a more angiogenesis during that time period. And the balancing of this activation and deactivation make the embryo survivability, sustainability in the maternal immune system will be there. If there is a more activation, there is a problem. If there is a only deactivation, there is a problem. So now we need to find out where there is a more activation and when there is a more deactivations. Now let me understand what's going. This is the extravillous trophoblast. This is the C receptor, right? And after this C receptor, suppose they have only HLA-C1, that means C1. If they have a C1, then they are going to activate the decidual natural killer cell by in between there is a ligand, there is a protein. There is a protein, and that protein, it is called as a KIR, K-I-R. And that means C1 is having a receptor on the KIR, and that KIR is having a 3 variety of receptor. The red one, it is called deactivation. The green one, it is called activation. Now, if they have a KIR, like if they have a 80% all red one, that means 80% receptor is, if we find the genes of 80% are red, that means genes are more having a receptor where it is deactivation, then it is called AA. And if it is 80% are green one, then more activation, then it is called BB. And if the 50% is activation and 50% is deactivation, then it is called AB. So these are the different type of, by that they will activate or deactivate the decidual natural killer cell. So let me explain that. This is HLA, again extravillous trophoblast. If C2 is there, then C2 again, C2 is always having a receptor on the red one. That means they are always having a high affinity to go by the deactivate the natural killer cell. Where the C1, if it's there, they are having a high affinity toward the green one. That means they are activator. They will activate the DNK by the key BB. So these are the different receptors. Now you will find that Dr. Jayesh, where this C1, C2, where this C will come to the embryo, they're going to be inherited from the parental genotype. So if the parent is having like this, suppose your parent is C1, C2 and C1, C2, then your embryo is 25% all C1, 25% is all C2, and another thing that what we want, that C1, C2, that means 50% is C2, C1 and combination. So now you understand that homozygosity of this HLA C1, C1 and C2, C2 will always C1, C1, that means activation. They will only activate the decidual natural killer cell, and C2, C2, that means only have a high affinity toward the deactivate the decidual natural killer cell. But there are a lot of polymorphic variety in the couples. You can see this couple is having a more C1 because C1, 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 C2. Here you can say C1, C2, C2, C2. That means in this couple, 50% embryo will homozygous. They have a more C1 embryo. And in the right side of that, the embryo will have a more C2 embryo will there. And this homozygosity is often associated with the recurrent implantation failure and recurrent pregnancy less, that we need to find out. Why? Because only C1, that means activation. All embryos, suppose the couple, we had seen something about all the, when there is a multiple pregnancy loss, then when we do HLA typing of the husband and wife by the their blood, then both HLA type is C1, C1. It means that embryo will definitely convert into only C1, and which having a more activation will be there. And if you have a C2 only, so look at this couple. We do have a lot, those couple are having a RIF and RPL. They both couple are having a C2, C2. So that's why they're all embryo is C2, C2. Homozygosity will turn out lead to only activation of the embryo or only deactivation of the embryo. And these are the embryo is going to be lethal for pregnancy loss, and also pregnancy failure will be there. So now I want to say that Kir is going to recognize the HLA class 1 molecule. And if the Kir is having a AA, let me tell you, AA, that means more inhibitory signals. And if there are having a genes which is called activating genes, 80% activating genes, then it is called BB. If it is 50% activating and 50% deactivating, then this is called AB. And by that, they will going to be modulate the natural killer cell activity. So this is the couple I want to say that. If there is a C1, C2 and C1, C1 couple, what will be the probability? Their probability is 50% of their embryo will have a C1, C1. Now, if they are having a Kir is BB, that means mother Kir, mother is having a maternal mother. When we do the maternal blood test, we'll find out and we'll say something, what is the genotype of the Kir. The genotype is BB or AB. That means they are having a more activating receptor. Now C1 itself is having a more affinity toward activation, and their Kir is also BB activation. Then again there are more chances of pregnancy less. But what I want to say that deactivation is always better than deactivation will be there. If there is a activation, it is more better than the deactivation is there. And this is what I want to say, that this affinity of C1 and C2 and balance will play a role, specifically in RIF and RPL will be there. So this is the good diagram. What I want to say, that this is the blastocyst adhesion, and after blastocyst adhesion, the extravilous trophoblast, there is a C receptor. Now we can find out whether the embryo is C1 or C2, both C1, both C2, that we can find out by the PGT and also the HLA of the embryo. That is what we are doing in our clinical practice. And also we can find out the key receptor, whether it is AA, AB or BB. And the combination is lethal. Now, if you have a HLA which is called C2C2, and if you have the key, it is called AA, then this combination is very bad, and this will give a more pregnancy loss or maybe a recurrent implantation failure, because there is no activation of the decidual natural killer cell. So this is how we can open beyond immunotolerance. We need to open the HLA type of the embryo probability, or we can also go by the exact HLA type of the embryo by the biopsy of the embryo. And also we also know the KIR ligand from the mother, and by that we can consider which HLA KIR complex is good. It will give a good prognosis to transfer as a hierarchy in the next, when the patient is already having a 3 pregnancy loss or maybe a 3 implantation failure will be there. So now we understand that there is something which is called first is immunotolerance. Then we need to also find out the identification whether the embryo is having a C1 C2 or C2 C2 or C1 C1, and we also find out the KIR from the mother, and by that we can find out that which complex is going to helpful to prevent this pregnancy loss as well as miscarriages. Now it's not only that. I want to say that when this embryo will go in the maternal blood system, they have a HLA class 2 system. So where I think so, when the embryo will go in the blood, there are so many autoantibodies are there. If there is a high level of autoantibody, again there is a miscarriage or implantation failure is there. So that also we will have an answer by HLA typing of the husband and wife. The simple test that we can do by the HLA typing of the husband and wife, by that we can see the probability of the HLA type of the embryo, and also the autoantibodies, level of the autoantibodies which is present inside the predisposing autoantibodies presence inside whenever the embryo will come inside the maternal immune system. So this is with the use of the chat GPT, I used to say that embryo is automatic car. So if you see embryo automatic car is having engine that means genetically normal. They looks normal, that morphology is normal, that means their mitochondrial level is normal. That means the fuel is there. But not only fuel and engine is important, it's also important that accelerator and brake. So accelerator, that means biological accelerator means C1. C1 is always activate your uterine natural killer cell. And C2 is a brake. They will always reduce the activation of the decidual natural killer cell. So during the implantation, your embryo car will travel in the maternal immune system. You need a balance. You need a balance. If your embryo is a C1, C2, heterozygous embryo is always better than the homozygous embryo. And the worst embryo, it is called C2, C2. That means what I want to say that activation is always better than the deactivations. So whenever the patient is having a multiple IVF failure, multiple implantation failure, multiple pregnancy failure, this identification of the HLA is so important, and which will give you the hierarchy that which embryo we can transfer. And ultimately, it will allow the embryo to transfer and penetrate, and that go into 9-month pregnancy will be there. And this is the beautiful study which was published in 2020. It's all are retrospective because it's difficult to get the control. And when they find out that what is the combination, which combination, the maternal killer cell and HLA combination and recurrent pregnancy loss, and what they exactly see that the RPL which was find out, it is higher when there is a C2C2, highest RPL which was found in C2C2 combinations with AA, and the C1C1 is also the second most highest RPL will be there. But whenever there is an embryo is heterozygous, C1C2 HLA is there, then the recurrent pregnancy loss is lesser compared to what. This is one more retrospective data in terms of HLA KIR combinations. And what they say that the number of patients is around 500 patients which was studied, and that 500 patients they find out the which HLA KIR complex. Look at that. They say that when there is a HLA KIR A is there, and if there is a C2C2, then the high level of the pregnancy loss which was observed. And C1C1 homozygosity is having a higher pregnancy loss compared to the heterozygosity. Now by that, definitely we can treat the patient going forward to select the embryo. Or also we can find out, we can counsel the patient that you are having a very worse prognosis. You might require donor egg or you might require surrogacy because your KIR is AA, because your all embryo will going to predispose as a C2C2. These are the conditions that how we can manage. This is our own 65 patients retrospective data, 63 FET cycles. In a combination, we have a same conclusion. When there is a homozygous HLA and the AA is there, the chances of pregnancy loss and pregnancy failure is higher compared to the C1, C2, and compared to the BB, the AA is having a higher pregnancy loss and the implantation failure will be there. So this is what about you can prioritize the embryo. You can also advise in a very bad prognosis patient that what will be the HLA type embryo should be transferred, or you can also advise for the donor egg, or maybe sometimes you can also advise the surrogacy, which is might be improve the output of the recurrent implantation failure and recurrent pregnancy failure. So what is my conclusion? HLA type offer best prognosis. C1 offer the best prognosis among the option, right? If you have a C1, C2, C2, I say C1 is better, but again, homozygosity is not better. AA is a worse prognosis. And we had seen something about less than 5% of the female do have a HLA key as a AA. Rest of the all female do have a BB, AB. So it's a AA is not that much of common, right? So now let me understand by the whole conclusion. We have when we talk about the recurrent pregnancy loss and recurrent implantation failure, we should talk about the genetic compatibility. That means sharing. If there is a couple is genetically compatible, then there is no immunotolerance, there is a pregnancy loss. If the signature of the embryo is homozygous and the combination with the key is not good, there is a pregnancy loss. And if there is a more autoantibody in the maternal blood system, that means systemic interaction. These three things are important: sharing, signature, and systemic interaction. So whenever we want to find out the reason behind the implantation failure and the pregnancy loss, we need to go beyond, and we can find out by the HLA report. We can come to know what exactly going wrong, whether it is a sharing is there, whether it is a signature of the embryo is a problem and key complex is a problem, or whether there is a high level of autoantibodies inside the maternal immune system, which is a problem will be there. Look at this one. I would like to say this is one of the example. Look at that sharing. Out of 12 alleles, there are 5 alleles are sharing common. You can see on A 0101 is common. If you see on B 5757 is common. On C 0707 is common. And also in the systemic D part also a lot of common is there. So 5 alleles are common, and this patient is present us with more than 5 pregnancy loss. So what I want to say that when there is, and we measure the paternal antibody by a blood test, we know that paternal antibody titer is very low, and these are the, or absent, and these are the conditions. I want to say that they are just act like, because their alleles are matching, they will might be a husband and wife. I used to counsel my patient, you will act as a sister and brother in the immunology, and which in turn leads to more miscarriage. So for that, we need to go ahead by LIT. So when we check this 12 alleles, and if there is more than 45% match is there, then LIT. So my message is very clear. Don't send your patients only on the verge of a very simple test where we can say the uterine nasal killer cell estimation and the cross match is negative, and the TNF alpha, which is about to always high level even in the normal pregnancy. So I don't believe on this test. We will go by definitely by the HLA typing, and we will see that there is genetic compatibility, more than 45% genetic compatibility. Then we will do paternal antibody test by the maternal blood system, and if there is no paternal antibody system is there, that means she doesn't require husband LIT. There is no role of husband LIT. And please don't do any LIT in the donor egg cycle and embryo. Already you are changing the donor, then why you are doing a LIT? It's all about that you can do donor LIT. So we are doing donor LIT in our clinical practice. Basically, when patient is having a recurrent pregnancy loss and recurrent implantation failure, only and only less than 3% of our population require donor LIT. 97%, the reason behind will be different. So don't jump on and to give all the LIT, unnecessary empirical LIT is having no role. Let me tell you. Yes, so you have to just go by the HLA typing and just measure the genetic compatibility is there. If the alleles are more matching, then you can go by the donor LIT. This is one more publication which was published in 2022, and it says that whenever there is HLA sharing, that means compatibility is more than 2 alleles. They are saying threshold is 2. In my clinical practice, I am always saying that more than 5, that means yes. My clinical experience, if the more than 5 alleles are matching, then I will definitely go by donor LIT if there is a previous history of recurrent implantation failure and recurrent pregnancy loss. But 2 to 5, I still be to transfer genetically tested 1 or 2 embryo. Again, if there is a pregnancy loss or implantation failure, definitely adding more implantation failure and more pregnancy loss in 2 to 5 compatibility, then I will go by a donor LIT will be there. So more than 45%, that means more than 5 alleles matching, definitely will go by the donor LIT. And I think so this is my own the study which was on the donor LIT, and which is again 65 patients evaluated. And after donor LIT, we have got tremendous output. The pregnancy rate, which was higher compared to the husband LIT, that is what we compared here. So that's why we shifted our practice to only donor LIT. Donor LIT will produce, because she required donor LIT, there is no meaning of the husband LIT will be there. Now, what about this is the immunotolerance? Then this is about the systemic interaction, HLA-D. And this HLA-D will give you actually idea that how much autoantibody will be there. I think so for that we need a immunology support. And I do have a one immunology support from Bangalore. I think so Sarajan, Dr. Vasanti is with me, practicing with me. And we are getting exactly the output where systemic inflammatory index is higher, where autoantibody is higher. So I will tell you something where immunotherapy will be indicated. Apart from LIT, I said LIT is only indicated less than 5% or less than 3%, and only donor LIT, no role of most of the time husband LIT, and that will be only conducted by HLA report, where there is a HLA-R matching HLA, more than 5 HLAs matching, I will suggest donor LIT. After that, this HLA-D, these are all different HLA-D we can find out, and by that we consider who is at high risk. Our immunologist will suggest that where there is a high risk will be there, and then they will advise. Now I will share my experience of the immunotherapy. You know that there are different type of immunotherapy. This is the tacrolimus, prednisolone, SCQ, ecosprin, the probiotics, vitamin D, vitamin E, high dose of low molecular weight heparin, intralipid, intravenous immunoglobulin, or surrogacy is the last part apart from immunotherapy. So where to give all this thing? Because we need to, I don't believe in the empirical use of the immunotherapy. This is one study which was published in the fertility sterility. And again, here the embryo which was not genetically tested, and the evidence is not strong enough, very low evidence. And that's why we are still on belief there is no role of empirical use of the immunotherapy. But what is the role then? Where we can do the immunotherapy? First step is single embryo transfer. Genetically tested embryo transfer and single embryo transfer is first test. And then you can take on the decision on the immunotherapy. So recurrent implantation failure, yes, you will do genetically tested embryo transfer. Recurrent pregnancy loss, again, you can do genetically tested embryo transfer. Don't do double embryo transfer. Again, it will increase the immunological load and abnormal immunological interaction with the maternal immune system. It is always better. I shifted my practice to only single embryo transfer in my clinical practice. So after single PGTA normal embryo transfer, now you need to conduct HLA typing. So you have to do the maternal husband and wife blood test. And I think so immunologist will give you the exact HLA typing and at probability of the HLA of the embryo that you can consider by after the HLA typing. You can also see the genetic compatibility report in the HLA typing report. And you can also see the systemic autoantibodies, predisposition of the autoantibodies in this HLA report. Right? After that, I think so where I can advise tacrolimus, if there are more inflammatory elevations, HLA will be there inside, then you can go by the tacrolimus. So we are not giving tacrolimus to all. We will identify which are the group of the couple, those who are diagnosis on the the HLA report, they have a more inflammatory elevation, then and then we can give a tacrolimus. Now, where we can give the GM-CSF. So I'm not giving GM-CSF to all or GCSF to all. Only if my husband and wife both are having HLA C2C2. So embryo is always C2C2. And if the Keir report is AA, then yes, I will go for the GM-CSF. And if there is a Keir AA, and if they are having a good HLA embryo, but they still have a more pregnancy loss, then also I will give a GM-CSF. Rest of the patients, I will not give GM-CSF. Then when I can give a donor LIT, I will give if there is I will assess the HLA report, and if there is a genetic compatibility is there. If there is a more than 5 alleles are matching, that means a compatible report. And if there is on the C receptor, there are all alleles are matching. These are the only 2 conditions where I can give donor LIT. So let me tell you, I'm just individualizing. I'm not giving LIT all. I'm giving less than 5% when there is a genetic compatibility. I'm giving tacrolimus then when there is an inflammatory evidence. I'm giving GM-CSF if my embryo is only C2C2 or if my Keir is AA, then I can give the GM-CSF. I'm giving less than 1% population IVIG. So I don't believe that empirical use of IVIG and giving IVIG and GM-CSF, this is all about that empirical therapy will work. I will give IVIG if there is a more autoantibodies on my HLA report. If there is a more autoantibody predisposition, yes, to dilute that autoantibody, right? We need to give this IVIG. And also, if there is an activation only, that means embryo is C1C1 and the Keir is BB. Or sometimes there is a Keir BB, right? Means the embryo is C1C1. Again, in these conditions, if there is a more pregnancy loss, you can give IVIG. But let me tell you something about that. I'm not going to be offered the IVIG. I think so. In my practice, I will give IVIG less than 1% or less than 2%. Those who are having a indicated pregnancy loss, indicated implantation failure will be there. And lastly, what exactly where I can give a low molecular weight heparin. I'm not giving empirically low molecular weight heparin. If husband is having a C07 LE, then I will add low molecular weight heparin. And if husband and wife both are having a high C07, definitely I will add high dose of the low molecular weight heparin. So I'm going to segregate my patient when to give high dose of the low molecular weight heparin, when to give the tacrolimus, when to give donor LIT, when to give IVIG. I don't prefer intralipid in this scenario. I will prefer only that prednisolone and IVIG for suppression. I will not prefer intralipid. So in my practice, I will always going to be find out which people are required. And this is my own publication of high HLA-07, which is already as a poster which was accepted in the ASHRAE in RPL, where high dose of low molecular weight heparin is really improve the clinical pregnancy rate will be there. So what is my conclusion? Abnormal signature. Let me tell you, abnormal signature embryo will increase RIF and RPL. So if you have a homozygous signature embryo, and if you have a AA Keir typing, definitely it will increase the pregnancy loss. Sharing will require donor LIT. So don't give LIT as an empirical to all implantation failure. And I don't believe in more husband LIT. Husband LIT is only investigated that every report is normal. And if there is a T-rex cell is low, rest of the all condition I cannot give a husband LIT. I think so. In yearly, in my patient, we are giving almost less than 0.5% husband LIT. So, and less than 5%, I think so. I said something even in the TG group, we are giving donor LIT. Systemic rejections can be be activated by the immunotherapy. And lastly, I can say in our unpublished data, 15 patient carrying C1C1. So when there is a homozygosity is there, if C2C2, C1C1, these are the case where maybe a donor egg or surrogacy is required. And where I think so we can give immunotherapy, we can explain the prognosis of the patients and embryo, and then we can find out. We are at present we are doing a HLA type of the embryo, and also transferring a single HLA type embryo in a certain patient, those who are having a multiple pregnancy loss and multiple implantation failure. So single embryo transfer strategy is a way forward to treat any immunological related implantation failure or rejection. Let me tell you, the people, those who are transferring a multiple embryo, they cannot practice and they cannot investigate more immunology. First, shift your practice on the single embryo transfer, maybe PGT normal embryo transfer as and when required in the this much of difficult case, and then you can think about to investigate about the immunology beyond it. So thank you so much. As far as concerned, hope I able to open the very difficult topic. And I believe that if you are really pure, how do you see the impure? For what is within is without. We cannot see impurity without having it inside ourselves. This is one of the practical sides of Vedanta. And I hope that we shall all try to carry it into our lives. Our whole life here is to carry this into practice. Thank you so much.
Thank you, sir. Thank you so much. So I should say this was a wow journey for us with immunogenetics today. And we had imbibed lot of information. As one of our panelists had told, we need to sit and go through the information which you have told.
I
And
think that you need a lot of basic and whole master class. I think so. We are coming in Bangalore on 27th July, and we are basically opening a association, All India Association for immunology only, because now there is a need of immunology, to talk immunology, to learn immunology. And also we also believe like that now people should learn immunology and treat the patients not empirically. All the immunotherapy, I think so, recently I got something like thymosin alpha people are using here and there. I think so, without any confirmation, the empirical use of immunotherapy is having no role. So I believe that it's better that this is the right time that we can go ahead with the how we can find out individualizations, where that I already said that we already on the verge of completion, that where to give donor LIT, compatibility is there. So we never give LIT as an option, a very open option to all, and saying that LIT is work for all, which is wrong. Never use immunology science when you are doing donor egg and embryo donation transfer. It's only work when you are doing own gamete transfers. So if you are shifting your patient on egg donation, embryo donation, there is no point, right? I am not doing any immunology investigation in my donor egg and embryo donations. We are only and only doing when there is a own gametes, because in own gametes there is no immunotolerance. In own gametes there is a something like that their HLA, uh, the embryo type is need to change or need to find out. And the body, because if you do surrogacy there is no immunology. It's all about that. And if you don't do surrogacy, then you need immunology suppression, just like IVIG or all these things. So I think so we do have a lot of segregation, that whom to give which immunotherapy, that we can discuss very in detail as and when possible. 20.
entirely change the clinical practice of IVF clinicians, because
Yes,
most of us, we don't have a proper data, and there are a lot of empirical therapy going on. So
yes,
this is a very good eye opener for us also. Sir, I'm really sorry. We are just running a lot of time, and we need to start with the panel discussion. Few of
yes,
the
yes, yes,
will
yes,
leave
yes.
by 4 o'clock. Um, Sir, can you stop sharing the
Yeah,
screen?
yeah, yeah, I will stop the show.
Thank you so much, sir. It was a very beautiful session, I would say. And people are asking for your lecture because few people have missed the session, and they want to go through the slides. Uh, Okay. So without wasting much time, we will go for our panel discussion, which is discussion about RPL at different gestations, and we have moderator Dr. Usha Vishwanath ma'am, who's director of Kanchi Kamakoti Hospital, and she was former head of the department in Sri Ramachandra Medical College, and who has got vast experience in UG/PG. And I would like to invite our panelist for the session, Dr. Vijay Lakshmi Gnanasekharan ma'am, who's Associated Professor of OG in ACS Medical College, And we do have Dr. Bhuwana ma'am, who is a very active participant in our ATN RCOG. And we also have Dr. Meena Mahalingam, active member of Oxy. And I would invite Dr. Tara ma'am from Fernandez Hospital, who's really known for her dedication and contribution in RPL. And a very warm welcome, ma'am, Dr. Gigi ma'am, from the renowned institute, head of the department from CMC Vellore. Thank you, ma'am. Thank you so much. I think over to Dr. Usha ma'am to go ahead with.
Very good afternoon. Am I audible, Dr.
Yes,
Geeta?
ma'am. Yes, ma'am.
Yeah. I'll
Yes,
share
madam.
my.
Not able to see you, but that's okay, ma'am. No problem.
Geeta, unmute the others.
Yes, ma'am.
Okay, I'm sure you can see the slide. So we'll start right away. I can see just 4 of the panelists. I think Vijay Lakshmi madam is there, Dr. Bhuvana is there, Dr. Meena is there, and I don't see Dr.
Professor
Tara.
Gigi is there.
Usha, I'm here. I think I'm in the
Doctor, yeah, I'm also there.
Okay, fine. Okay.
there, Usha. I think it is in the attendee list, I think, not a faculty.
Please kindly put off your mic.
Thank you, ma'am. I think we will start right away. We know that I'll just go on to the case scenario. This is the first case. A 24-year-old fourth gravida with previous 3 abortion is at the OPD and she's come for counseling and further management. She had 3 missed miscarriages in the first trimester. I have missed that out, and has no other risk factors. So 3 first trimester missed miscarriages. And may I ask Professor Julia Elizabeth as to what is the focused history you wish to elicit from this patient?
I'm relieved that her age is less. Her history, basically, I would also want to know how many years she's been married. I would spend a lot of time giving her psychotherapy and also take her through what the final, that though there are causes for recurrent pregnancy loss, even if there are abnormalities, 71% of them go on to a viable pregnancy. I would reassure that even if there's an abnormality, 71% go on for a viable pregnancy. Since there's no difference between treatable and untreatable causes, I would tell her that possibly karyotype.
No, we are looking at the history here. What
Correct.
focus?
Only history? Yeah.
Yes.
So the history I would like to elicit, the family background, not much more than this. Family background, whether consanguinity is there, whether there's consanguinity, and this was the only, if it's only history, this is probably what I would want to know.
Madam, can I add, madam?
Yeah, please.
Dr. Meena. Madam, just would like to add on, asking her the weeks, whether there was an increase in the gestational age in the loss of the pregnancy, madam, whether it was like 6, 7 weeks or 7, and then gradually increased to 8 weeks. Because we have to think also of the delay or the Kesowitz law, which states that there is a increasing in the gestational age by which the pregnancy increases and then gets a fruitful pregnancy. That also I would like to add, madam. And the interval between the pregnancies, whether there was a spontaneous conception or whether there was any ovulation induction, whether she conceived with any IUI or any other procedures, IVF. And how was the pregnancy terminated, whether there was a medical termination or secure done.
So you would like to know whether it's spontaneous or induced, and you want to know the gestational age. Dr. Vijay Lakshmi, you wanted to add something? Yes, please go ahead.
Yeah, I wanted to say the same thing. The detailed obstetrics history about all the 3 miscarriages that she has had, which Meena has already told. I would also like to ask for a family.
Voice is not clear. Vijay, madam, voice is not clear.
Yeah.
Actually, I can hear you. இன்னும் கொஞ்சம் louder பேசுங்க ma'am. Yeah.
Okay. So now I'm using my earphones, so probably because of that, should I disconnect or not? I do not know. If I'm still not clear, tell me. Huh? Now is it okay?
I am able
Hello?
to hear actually.
Yes, ma'am.
Okay,
Much
okay,
better,
fine,
ma'am.
fine. So the detailed obstetric history is what Meena has already elicited, that we would like to hear from her. Consanguineous marriage is another thing, yes.
Yes.
And then about her personal history, any past medical history, is she a
Yes.
known hypothyroid? Is she on any thyroid medication? Any other medications that is on she is on? Any other medical disorders that she is having? Is she a
Okay.
known diabetic or anything? And family history of diabetes, family mother having hypothyroidism, or the other histories which I would like to elicit.
Okay, thank you. So what are the investigations would you want to suggest for this patient? Anyone, Dr. Bhuvana or?
Yeah, I agree with the history. Adding to that, we would like to also know about the occupation, and we'll go through what are the treatment modalities that she has undergone in the previous miscarriages, whether any history like previously aspirin was given or low molecular weight heparin was given, any genetic tests were performed. If so, if it is available, we will go through all that records as well. And as Dr. Vijay ma'am already pointed out, ma'am, we have to really go through whether they have any symptoms of hypothyroidism or diabetes. If there are any symptoms, most likely we should have a specific explanation to the patient as to why this is happening. So we probably would like to do a complete blood count with as well as a thyroid profile and a thyroid peroxidase antibody if indicated, if there is a hypothyroidism, and the diabetes and HbA1c and fasting and postprandial blood glucose. Apart from that, because it is 3 miscarriages, I would definitely like to do an anticardiolipin antibody IgM and IgG and beta-2 glycoprotein as well. But thrombophilia screen at this point of time is not recommended because it doesn't have a high evidence. So we would like to stop with anticardiolipin antibody.
Okay, thank
Madam,
you.
also I would like to add on with the investigations of the previous pregnancy, whether she has had any testing of the products of conception was done. That also in the
Yeah,
history I
that
would
is
like to
something
add,
that
madam.
Dr. Bhuvana already talked about. Okay, good. So when will you
Okay.
advise her to plan her next pregnancy and how will you counsel? Can I give this to Dr. Meena? And just think that I am the patient's family and please talk how you'll counsel.
Madam, so in between the pregnancy, as Bona madam had told, I would like to do all the investigation, and with the results of the investigation, if needed.
Sorry to interrupt. Sorry to.
Yes, madam.
Yes,
Meena,
yes.
are you driving or somebody else is driving?
No, I think
Madam,
someone else is driving.
Yes, no problem, madam.
Hmm.
So, I would, after getting all the results, if everything is negative, I would ask her to have a conception, starting with the high dose folic acid, madam, 5 milligram folic acid. I would like to advise her to take the pregnancy. If there is no cause found, just giving her a tender, loving care, as already told earlier.
So when will you advise her to plan the next pregnancy?
Within 3 to 6 months, madam.
No, Usha madam, I would like to wait for the results. We have done the investigations. Let us
Yes.
wait for the results to come. We look for the APLA screening we have done. We're looking for thyroid. We're looking for diabetes. If there are any issues in all that, that has to be addressed before she plans her next pregnancy. Of
Okay.
course, APLA only after the conception, but the thyroid and diabetes has to be taken care of before the next pregnancy is planned. And since
Okay.
it is
Anybody?
the third time.
Yes, this is the 4th pregnancy after 3 miscarriages.
Yeah.
Bhuvana, you want to add? Dr. Bhuvana, you want to add?
Yeah, as because the patient, the couple will be definitely anxious, ma'am. So definitely, I would like to add low dose aspirin even before they plan for the pregnancy. We'll definitely wait for the APLA and the ANA reports and beta-2 microglobulin reports. Following which, we will pre-conceptionally itself folic acid and ecosprin should be added. And once the pregnancy test positive, we would like to add on a low molecular weight heparin based on the APLA test reports.
Okay, so everything is like focusing towards the APLA now.
Yeah.
So
So
now,
there is
if
no
suppose the
evidence.
APLA is negative,
There is no
suppose APLA.
evidence.
Yes,
There
yes.
is Yeah, there is no evidence to show that you advise the couple to wait for 3 to 6 months because we are unable to do research on that. So the other problem with this is that the patient is very stressed, the couple is stressed, and therefore as soon as the results are out, I think we should encourage them to continue intercourse and become pregnant as whenever it happens. And without much delay to avoid further stress, because there's no evidence to show that delaying pregnancy decreases chance of miscarriage.
Okay. Dr. Tara, do you want to add before Vijay ma'am, please mute yourself.
Yeah, there is a lot of disturbance, Usha. First of all, BMI is one thing I did not hear from any of the panelists. I would like to know about her BMI. Second is, I would like to make her comfortable, sit and talk to her, because you told me, you told us like, how would you counsel? Dedicated space, dedicated time to talk to these couples and get all the investigations what were enumerated. Unless until I'm sure it's an Aplar syndrome, it is not right to give aspirin prior to conception. This is what my take home message is. Other investigations would be like all were added, and it is the 3D ultrasound of the pelvic organs which we would like to look at. And we counsel the woman when we talk to her about a pap smear, because most of these women, they don't have a pap smear. They'll get, so we will counsel her before the ultrasound pelvic organ pap smear. Okay, Usha? And I thank you so much. In another 10 minutes, I'll reach home and again I'll log in, but I'm on. If any
Okay, fine,
disturbance
no
is
problem.
there.
So
Thank you.
I think
I
the only
disagree.
thing that
I disagree with the pap smear. This couple is going through a lot of stress. We don't want to do unnecessary tests that are not going to help her now. She's come for a particular problem. Pap smear is if she's got promiscuity or something like that. So we have to be careful. I always worry about patients with recurrent pregnancies.
Okay, I think we wouldn't debate on the pap smear. What we will, my only question is, how many of you agree for a preconceptual aspirin? Because
I agree, there's no role for preconceptional aspirin.
Okay, Dr. Vijay? Okay.
Madam, if Aplar is positive, then we give, madam, as Bona madam told. Otherwise, we do not start them, madam.
Okay, fine. We'll move on to the second case. 32-year-old third gravida with previous...
I think there has to be some clarity. If the Aplar is positive, we start it only in the first trimester. I don't think you do give it periconceptionally. There's no evidence for that as yet.
I also agree with you, Professor Elizabeth, on that. Anyway, we would start once she conceive and not the pre. Okay, we'll move on to the case scenario 2. 32-year-old third gravida with previous 2 abortions, 2 miscarriages at 16 weeks and 18 weeks with no risk factors. And in both pregnancies, she ruptured her membranes prior to expulsion. And she had to travel during both pregnancies just prior to the miscarriages. She's very apprehensive that the travel has been the cause of both the mishaps. So how would you educate her and the family? She is in the self-blame mode, thinking that the travel has probably triggered both the abortions.
Can I take the question, ma'am?
Yes.
Yeah, actually, because this is pointing towards more at the same period of gestation in both the pregnancies, it is quite unlikely that she had ruptured her membrane during travel. Travel could have led to the rupture of membranes in a short cervix, or there could have been a bulging membrane or a very weak cervix that would have probably aggravated a rupture of membranes during the travel. Definitely, she has to be evaluated for a high vaginal swab for a possible bacterial vaginosis, and urine culture has to be done, and a serial cervical length has to be measured. Probably we would also history based, probably I would like to place a cerclage if it is the cervical length is around a lower limit, say if it is around 2.5 centimeter in the first trimester. Definitely a history based cerclage would have benefit. But before that, I would like to treat that bacterial vaginosis and a urine culture because it is very important that she has lost 2 babies at 16 to 18 weeks, quite a difficult situation. And this time we
I
should
want to
not make any
disagree with
mistake.
you, madam.
Ma'am, please wait, ma'am.
Yeah.
So there are two things. Are you going to be doing bacterial vaginosis, and are you going to be the travel probably is definitely not the cause. We just need to reassure them. Ma'am, please go ahead.
I say, basically, this case, we have to make sure there's no structural problem. We should do a 3D ultrasound, preferably to look for any structural abnormalities of the uterus, subseptate uterus, and fibroid uterus, etc., as well as cervical integrity. Bacterial vaginosis and all are still theoretical. There is no evidence to show that it causes these problems. Yeah. Thank you.
Okay. Anybody else? Tara or anyone, Dr. Tara or anyone else want to add on?
Two things, Usha. Yes, I agree with the ultrasonography and structural abnormalities. Second thing is, please refer antiphospholipid antibodies, 6 clinical domains.
Yes.
Proven before
Yes.
pregnancy. It is recommended to give low dose aspirin. There is a recent article. I'll just share it with you. You can share it with everybody. Only proven APLA, there is a role for preconceptional aspirin, not for 6 months of folic acid like that. Once the couple is ready, only we start. Thank you. Yeah.
Okay, so anybody else wants to add? So this looks more like a structural problem with the cervix. It looks like a pointer for incompetence of the cervix. Vijay ma'am, do you want to add something to this?
No, madam, I would like to, even whatever Gigi madam said also, no, other problems of anomalies of the uterus.
Oh, yes,
The
yes.
ultimate thing is only cervical incompetence there also. So
Yes.
definitely a 3D ultrasound is a must. If we don't have a 3D, a 2D ultrasound along with a saline infusion can be done, or lower resource settings, HSG can be done. But whatever, we have to look for cervical incompetence in this patient as well as structural abnormalities.
Okay, so if
and we
it
have
is
to counsel
cervical
her for that.
incompetence, thank you. So if it is cervical incompetence in this patient, when would you want to put the reinforcing stitch for this patient? At what gestational age? Dr. Meena.
When the,
Okay,
Madam, I would like to confirm, madam,
No,
because
no, after
NT scan,
confirmation, everything is confirmed, and now you are deciding on the reinforcement stitch.
when we do the NT scan, we do it a little ahead, probably by about the 11th or
ruling
the
out
12th week. If we do.
anomalies between 12 to 14 weeks, we would
Okay.
plan the stitch, madam.
12 to 14. Vijay ma'am, you're saying something?
Yeah, same way, madam. 12 weeks anomaly scan instead of waiting to 13 plus 6. Let's do it at 12 weeks. Rule out the nuchal translucency or any other abnormality and plan a stitch at that time.
Okay, ma'am. How many of you
And
will
look for the
put her on?
cervical length also at that time.
Okay, so how many of you will give her progesterons after the cervical stitch?
I will definitely give her progesterone for the benefit of doubt. Yeah.
I
Yeah,
would
it's
also
only the
give
benefit of doubt.
progesterone,
All of
madam.
us, I think most of us will agree for the progesterone.
What progesterone would you choose?
An actual
Micronized progesterone, madam.
micronized progesterone.
Okay, so micronized progesterone, and for how long?
Till 34 weeks or at least 34 weeks.
Professor Elizabeth, for how long?
Yeah, I would give it to her till 34 weeks. But if it's expensive, if she can't afford it, and you have good nursery facilities, maybe by 32 weeks.
We go till 28 weeks, madam.
Okay, Dr. Tara, would you put her on progesterone?
I beg to differ, Usha. We do the cervical length assessment, 2.5 centimeters, vaginal progesterone till 34 weeks.
So you wouldn't be giving her progesterone?
Empirically, no.
Me too. I too agree. I know this can go on as a debate so we will leave it at that. Okay, case scenario 3, 30-year-old, 5th gravida, 4 abortions, 2 miscarriages in the first trimester, following which she has lost the pregnancies at 14 and 15 weeks. I hope I don't have such patients. She's married to her maternal first cousin, and there is no obvious positive history in the family, obesity with an increased BMI and a height of 153 centimeters. What do you think are the possible causes that you have in mind in this patient who has a combo of the first and the second trimesters? Professor Elizabeth. Are you muted, ma'am?
I think
Yeah,
you
yeah. We have to rule out diabetes. She's obese.
Okay.
That PCOD and its associated luteal phase defect and stuff like that. But before that, the lifestyle modification is very, very important, because it's well known to know that to bring down the BMI is probably very important. We can counsel the patient, but karyotype. We have to be pragmatic sometimes when you order tests, depending on what the patient can afford. So I always tell my the couples that I counsel, I say that the chromosome analysis will tell you what you have, but there is no treatment. You can't change your spouse. So, so basically, I would advise her to lose weight, vehemently put her on a good lifestyle modification thing, and take it from there. And of course, all the other things that we have discussed now.
Okay, so you do a parental karyotyping in this patient. Anyone else wants to add on to this? Dr. Tara? Or Dr.
I agree, Usha.
Okay. Dr.
Madam,
Bhuvana?
I would like to check if there are any infections as well, syphilis, or if she has had a RPL evaluation, the test results, the lupus anticoagulant, anticardiolipin, and also the cervical incompetence. If she has had it, I would like to have the results of the investigation so that I can give the management.
Okay. Dr. Bhuvana?
Ma'am, I just lost the connection. I just got logged in again.
No,
So
2
what
first
was the outcome,
trimester
ma'am?
and 2 second trimester miscarriages.
Okay. So,
Okay, so will Dr. Vijay, you want to add something to this? Okay, I think we have lost her. So I think parental karyotyping was what was added to all the routine tests that we have done, and lifestyle modification, keeping in mind her obesity, is what you would. It's going to be a mirage, because we don't really know what exactly is causing. And if we have pointers like a cervical incompetence or anything in specific, we would address those in particular. Okay, this is the last case scenario. 35-year-old third gravida, para 2 with no live issues, has had previous 2 pregnancy losses at 26 weeks and 29 weeks with no obvious comorbidities. She's unable to recollect the history if there was a loss of fetal movements prior to both the mishaps. One was a stillbirth with early signs of maceration, and the other was a fresh stillbirth. So, what focused history would you want to elicit in this particular patient? It's
we
open.
should
Anybody
definitely
can
ask
answer.
whether she has any high blood pressure, whether she was initiated on any medications, like high blood pressure, whether she had edema, whether she had any convulsion, anything like that, ma'am. Because of
Hypertensive
26 and
disorders.
29 weeks.
Yeah. Early onset IUTR.
Early onset preeclampsia and the weight of the baby, ma'am.
Yeah.
Okay. Please
Also,
add
lupus,
on the others.
API-LA syndrome, we should rule out. Lupus anticoagulant, anticardiolipin.
So maternal disorders, APLA, then?
Yeah, syphilis.
Okay.
Any placental histopathology available, Usha?
Yeah.
So you'll ask for the placental histopathology, okay?
Any RH negative, what is the blood group? That's also need to be done, ma'am.
Okay. Unlikely, RH, fine. Any other investigations that you would do in particular, apart from all that has been explained?
Yeah.
Dr. Meena and Dr. Vijay.
Madam, I would like to collect the reports and see if there are any problems, madam, and then go with the management. Only these investigations,
Any
madam. Get
autopsy
all
done,
the
ma'am?
So let us say all
thyroid.
reports are normal. The placental histopathology and everything comes normal, and there are no clues with us. How would you proceed with this patient? Because many times that's what happens.
We give a tender loving care, madam, and careful monitoring, because she has improved on the previous obstetrics gestational age. So we need to keep her under frequent visits.
Yeah, or preferably admit her on the 3rd or 4th time. We can admit her, and if you find any sign of growth restriction or decrease like a volume in a good center with nursery care, deliver her early. So
if she's pregnant for the third time now,
yeah,
what
And
are the
FTS
special
should be
concerns
done
that
and
you will take care of?
ecospirin, definitely ecospirin from first trimester.
So you're going to put her on aspirin. How many of
Aspirin.
you disagree with aspirin?
If it's
no,
not
I
a
agree,
routine,
ma'am.
if it's not approved in APLA, we cannot give her routine aspirin, no?
No,
Okay,
madam,
so-
there are large studies to show that ecospirin definitely prevents early onset preeclampsia, and therefore we
Dr.
should
Bhuvana,
definitely, yeah.
would you start aspirin?
Definitely, I would start, madam, because she has
Okay.
lost 2 babies and there are no
Okay.
much side
Dr.
effects by
Meena?
starting a low dose
Yes,
aspirin.
yes, madam. I would
Uh,
start on aspirin, madam.
I
Okay.
would start, madam.
Okay. So apart from
Okay.
aspirin, when would you want to deliver this baby with close monitoring? You all wanted to give tender loving care and close monitoring. When would you want to actually deliver her? 26 weeks, 29 weeks, 2 pregnancy losses.
As much as possible, we should try to prolong, ma'am, because 26
Please
weeks
give us a
we can have
gestational
a
age.
higher perinatal mortality.
Yeah,
So
please
we
give
have
us a
to take her as
gestational
much
age
as
till which
Well,
you
possible.
would wait.
try to take it at least up to 34.
34.
I think 30 weeks in a good, if she's well to do, the patient is well to do, and she's had these 2 at 26 and
30
29.
weeks.
Yeah, 30 weeks in a good center.
Dr.
where
Bona, what is the number that you are looking at?
No, ma'am, I am actually not looking at any numbers. I am just hoping
No, I
we'll
want
take
a
little by
number,
little.
but
Once she
because
crosses
we should
28,
have a number.
yeah, once she crosses 28, I'll be happy to go to 30. Once she crosses 30, I'll go going to 32, like that. Provided the
madam.
Dopplers are normal and the
No,
fetal
the
well-being
If
is all right.
everything is
And the
normal,
sudden abruption is the problem. So even in the ward, we've lost patients.
Dr.
Therefore,
Meena,
yeah.
Madam, we would keep her under close monitoring and go on till how much ever, like as madam told, 28, 30, then 32, then 34.
tell
Till
me
then
the
we'll
highest
go on,
number.
madam.
at
My
least till
highest
34,
number is
that's why we
34.
should monitor them.
34 to
30.
36, madam.
34 to 36. Okay, so can I have a final word from Tara? What number are you looking at? Is she there connected?
Yeah, I'm here, Usha.
Yes.
Usha, if this pregnancy is going on well, I feel we shouldn't look at numbers, the confidence, the fetal, the
So
maternal
you will wait till
monitoring.
37?
No, 34 to 36 reasonably, because we have seen that they have a reduced fetal
Yes.
growth velocity. That is
Yes.
an indicator for delivery. Okay, thank you.
Yes. So I too agree, because the numbers will sometimes be a little disarray and sort of influences. So I think it's important. It's not very easy to answer these questions, because I know when you have patients of this sort, we are walking on a trapeze and we don't even know in what way the balance will tilt at what time. So we have to keep our fingers crossed, toes crossed, everything crossed till we have a good outcome in the mother and baby. So that's my last slide, and I would like to end saying the little feet of babies make the biggest footprints in our hearts. Thanks all the panelists. It's been great. Though we beg to differ, I think we have agreed on most things, and thanks for all your time.
Yeah.
Thanks
Thank
to
you.
Dr. Kundavi
Thank
and
you
the
very
team.
much.
Thank you, ma'am.
And
Thank
thank
you.
you,
Thank
logged
you,
in.
madam, for the
Yeah, ma'am. Suppose if
opportunity
this
given,
pregnancy
madam.
is also lost after the third pregnancy at 29 weeks, what is your number then?
You're asking me.
Then 28 weeks for fourth one at 28 weeks.
I will still be hopeful, and then I will continue to at least 32, 34 weeks. I don't know.
Do we really have to admit these patients the time they've lost the pregnancy, or what do you think about it?
I think it's better we do, because sometimes we may miss during the crucial time that pregnancies were lost. So monitoring is one kind of pacifying us that we are not missing out anything by sending them home at the crucial period of their pregnancy losses.
Thank you, ma'am.
Thank
They
you.
get a
Thank you,
tender
thank
loving
you,
care
ma'am.
in the hospital for a long time, madam. If they are admitted, they become friendly also.
Meena has poured out her tender loving care. I think
Yeah.
that really matters.
Yes, madam. That is the only major treatment.
Yes. Thank you. Thanks
Thank
to
you, madam,
everybody
for the
and all
wonderful
those who have logged
opportunity.
in.
Thank you, everyone. Bye.
Thank you, ma'am. Thank you, Kundavi ma'am. Geeta ma'am.
Thank
Bye.
you, Kundavai ma'am. Thank you, team at Triple M.
Thank you. Thank you. Enjoyed the panel.
Thank you,
Yeah.
Kundavi ma'am,
Thank
Geeta
you.
ma'am, for the wonderful opportunity given.
Thank you so
Thank
much
you, Usha ma'am.
for interacting in the
Co-panelist.
panel session.
Thank
Usha
you.
madam, this panel was really to us. So we just brought out whatever we generally tell or do. That's all. So that it was very lively. Thank you. That's
Thank
why
you.
I think lot of differences were also there. Thank you.
Yes, it's good to
Thank you,
have
Usha ma'am.
differences so that we also agree to disagree sometimes.
Yes, yes. Thank you so much. Thank you.
Thank
That
you
was
so much,
wonderful.
Usha ma'am.
Thank you. Bye.
Thank you.
Bye.
Thank
Thanks.
you, co-panelist.
Thank you, ma'am. Thank you so much. Thank you for moderating the session. And it was really wonderful having all gestations put in one place. So now I think we have come to the end of the session. We are having here Dr. Giovin. Ma'am, can you stop sharing the screen? We are having Dr. Giovin for vote of thanks today. She is a consultant here in IRM Triple M. Yes, Giovin.
Thank you, ma'am. It was so great watching this panel, ma'am, with all the six people who are carrying obstetricians with their experience and evidence. It made a beautiful collection of evidence at all the gestation ages covered. It was wonderful, ma'am. And I wish to thank at the outset our HOD, Dr. Kundevi, ma'am, for giving us this title, Recurrent Pregnancy Laws, and covering all the aspects of it. I extend my thanks to Geeta, ma'am, who was the master of ceremony and conducted the smooth going of all the events and collaborating with all the speakers. I wish to extend my thanks to all the three speakers, Dr. Deepa Tyagaraja ma'am, Dr. Kadirvel sir, and also Dr. Jayesh Amin sir, who joined with us and enlightened the recent advances and concepts in evaluation, genetics part, and highlighting upon the recent in immunotherapy also. And finally, Dr. Usha Vishwanath, ma'am, thank you, ma'am, for pulling out all the possible scenarios in all different gestation age and walking through the step-by-step approach for the recurrent pregnancy loss. Thank you, ma'am. I wish to extend my thanks to all the panelists, Dr. Vijayalakshmi Nyanashikran, ma'am, Dr. Bona, ma'am, Dr. Meena Mahalingam, ma'am, Dr. Tarakeshwari, ma'am, and Dr. Gigi Elizabeth Matthews, ma'am, who all joined us and gave this lecture. I thank our EDP team for extending the support, and I also thank Sahiti of Shield Connect for the computer support today. Thank you very much for the audience for your patient listening and your interaction with the interesting questions and possible solutions. Thank you very much, ma'am.
Thank you, Joan.
Thank you, ma'am.
Thank you, everyone.